Diabetes mellitus. We'll see all about diabetes mellitus. These are the complications of diabetes mellitus, that is neuropathy, retinopathy, nephropathy. This will be the risk factor for coronary artery diseases. Because there will be increased glucose level in the serum, it appears in the urine also, so glucosuria and hyperlipidemia. There will be lack of utilization of the lipids, so hyperlipidemia, negative nitrogen balance because of the protein. Proteolytic, it inhibits the proteolysis, so there will be negative nitrogen balance, and ketonuria. You can remember, like diabetes ketoacidosis also comes now, so ketos will also starts appearing in the urine. The ketone bodies are acetoacetic acid, acetone, and beta hydroxybutyrate. And hyperglycemia. In blood also the glucose level increases. When we say that there is a hyperglycemia, when fasting glucose level in the blood will be more than 126 or equal to 126 milligrams per deciliter, or postprandial after 2 hours of meal. If there is a 200 milligrams per deciliter, we say it as a diabetes mellitus, like hyperglycemia. There are two types of diabetes mellitus, that is type 1 and type 2. Type 1, where is a insulin dependent diabetes mellitus. This is non-insulin dependent diabetes mellitus. Insulin dependent means if we give the insulin, there will be he becomes normal. In case of juvenile onset, this will be seen in the early age, whereas in type 2 diabetes mellitus seen in the maturity, that is maturity onset. In type 1 diabetes mellitus, there will be destruction of the beta cells of the pancreas, so there won't be production of it is autoimmune disorder. There won't be production of the insulin. Next, type 2 diabetes. Type 2 diabetes, there will be abnormality in the glucoreceptors, or else there will be increase in the hyperglycemic hormones like growth hormone, glucagon, glucocorticoids, and all those. And there will be resistance for the insulin in type 2 diabetes mellitus. The hormones which increase glucose are glucocorticoids, growth hormone, glycine. All three are start from GG. Hormone which increases this glycogen, growth hormone, and glucocorticoids increases glucose level, whereas thyroxine also, this you can remember as G. Thyroxine, glucagon, growth hormone, and glucocorticoids increases glucose hormone, whereas glucose in the blood, whereas insulin decreases glucose in the blood. And insulin, first it will be pre-proinsulin, then it becomes proinsulin, and then insulin. In proinsulin, it will be 110 amino acids, then it becomes 51 amino acids. This is a proinsulin. It will be having A chain, B chain, and C chain. After the removal of the C chain, it becomes insulin. Proinsulin becomes insulin. A chain contains 21 amino acids, B chain contains 30 amino acids. Totally 51 amino acids will be present in this thing. Between A and B, there are two disulfide bonds. In A, there is a one intersulfide bond. Regulation of insulin, it is a chemical or neuronal or hormonal regulation. Neural will be vagal stimulation, sympathetic, the parasympathetic by vagal stimulation, and sympathetic stimulation. Whereas chemical regulation by the these receptors, VIP, these hormones VIP, GIP, and GLP-1. These are incretins. These are incretins. This regulates the glucose levels in the blood. And hormonal by three hormones: insulin, glucagon, and somatostatin. Alpha, beta, and delta cells in pancreas. Alpha cells secrete glucagon, beta cells insulin, and this delta cells secrete somatostatin. When there is a this is a regulation that I'll say later. There are three types of cells. Glucagon stimulates both delta cells and beta cells to secrete. Beta cells will secrete insulin and amylin. Delta cells will secrete somatostatin. So glucagon is stimulating both, whereas somatostatin is inhibiting both. So this is over. Only this left is insulin will inhibit the glucagon. Glucagon stimulates both. Somatostatin inhibit both, and then beta cells will inhibit this thing. And then insulin is an anabolic hormone. I am saying from the class notes, running notes, so please do cooperate. And there are the preparations of insulin. First we'll see the actions of insulin. Actions: it facilitates the glucose transport across the disease cell. It helps in the uptake of glucose and conversion of glucose into glycogen. Intracellular utilization of glucose, because insulin goes and stimulates glucokinase or exokinase that helps in the conversion of glucose to glucose 6-phosphate. It inhibits gluconeogenesis from amino acids and lactate, acetyl-CoA glucose will be produced. No, that will be inhibited. So glucose is finally reducing glucose. It is converting glucose into glucose 6-phosphate and reducing the gluconeogenesis, and it is helping the cells to uptake and then utilize it. So finally it is reducing the glucose level. It inhibits the lipolysis. Because lipids are not broken down, only glucose is broken down. Protein, it helps in the formation of protein. In the absence of insulin, free fatty acids will be increased, that will be converted into acetyl-CoA, that will be excreted in the urine, that is ketone bodies, that is acetone, acetoacetic acid, beta hydroxy, butyrate. It facilitates the amino acids entry into the muscle cells so that for protein formation, it helps in the formation of protein. It enhances the transcription, vascular, endothelial, lipotrophic lipase. It acts on insulin acts on three organs: liver, muscle, and adipose tissue. It helps in uptake of all these things, glucose uptake in all these three cells. In liver, glycogen will be there, no? Glycogenolysis will be inhibited so that glucose level is decreased. In muscle cells, it helps in the uptake of amino acids and helps in the formation of protein. In adipose tissues, it inhibits the lipolysis and decreases the release of free fatty acids into the blood. Insulin preparations, there are older preparation was from beef and pork. Then highly purified insulin was gained by gel filtration and ion exchange chromatography method. Types of insulin preparations are, you can see here, these are parenteral, these are oral. Oral insulin is not given, subcutaneous use is usually given. Rapidly acting, short acting, intermediate acting, long acting. Long, short to long, intermediate to rapid. Rapid is nothing but fast only. Insulin analogs like lispro, lysine, proline, aspart, glutamate, lysine, glu-lysine. And the short acting regular insulin. Intermediate acting, there are two: lente insulin and isofan insulin. Long acting, gal-argin, dead temir, insulin, gal-argin, dead temir. Now rapid acting, short, long, intermediate, rapid acting. Rapid acting, insulin lisopro, insulin aspart, insulin glu-lysine. Then short acting will be regular insulin, intermediate acting lente insulin and isofran, long acting insulin gal-argin and D-temir. These are the insulin preparations, and other parenteral antibiotics also there other than insulin, that is amylin analog. I told you beta cells also secrete amylin, that is pramlintide. 3 words you can break: pramlintide. And then glucagon like peptide 1 receptor agonist, that is exenatide, liraglutide, tide is common for both liraglutide, exenatide, liraglutide, pramlintide. These are the insulin preparations. This is all about the pharmacology of diabetic mellitus. If you find this video helpful, please do like, share and subscribe to my channel, and if you have any suggestions, let me know in the comment section. Thank you.